First of all, I would like to thank the organizers, particularly Dr. Rebecca Smith-Beidman, for the kind invitation and opportunity. Now, it's a very interesting topic, optimizing doses for abdominal imaging, uh, urogram, stone trauma, and pain. Now, in my career so far, I've wore several hats as a research clinical fellow, as a faculty radiologist, as a chief of CT, and now in my role as a chief of abdominal imaging. So I've looked at different aspects of optimizing doses for abdominal imaging. So in this lecture, I will try to provide mostly a clinical perspective as to, on a clinical front, what are the things we are trying to do to optimize doses for those indications for when a patient gets an abdominal CT. So with that, let's get started. These are my disclosures. So what I plan to do in the next 20 minutes or so is to discuss what one needs to think of when optimizing protocols of the abdomen from a mostly clinical perspective, focusing on protocols for stone protocol, CT urogram, trauma, and pain. I'll also discuss some strategies for radiation dose reduction and how the dose can be optimized. Now, when you think of radiation dose reduction, the two main pillars of radiation dose reduction on a population level, I think, is appropriate utilization and optimization of CT protocols. So let's talk about appropriate utilization, which I think is an integral component of any initiative to reduce radiation dose or to optimize dose for any imaging technique. Now, uh, when the question of imaging comes up for any patient based on the clinical indication, the first thing to ask is the imaging needed for this patient? And secondly, what is the right imaging technique for the given indication? And if the referring provider does decide to order a CT scan, are there any alternative imaging techniques without radiation exposure one could use? Now, a very useful resource for referring providers and for radiologists is the ACR appropriateness criteria, which are evidence-based guidelines which assist referring physicians and other providers in making the most appropriate imaging and treatment decision for specific clinical indications. Now, employing these guidelines helps providers to enhance the quality of care and contribute to the most efficacious use of radiology. Now, here I want to discuss about utilization of imaging in one important exam which is routinely performed in the abdominal division, that is CT enterography. Now, I know that topic is CT enterography is not a part of the topic, but here I want to show you how over the years, as utilization of different imaging techniques for certain indications has evolved, there has also been evolution in how different imaging techniques are used. So what we did was, in this study, we looked at the 10-year utilization in the trends in abdominal CT and MR utilization in patients with Crohn's disease. We looked at over 3,000 CTs and nearly 2,000 MRI in near 2,000 patients over a 10-year period from 2006 to 2015, and tried to look at how imaging was utilized for different indications in patients with Crohn's disease. What we found was predominantly both CT and MRI were used for patients with complications or patients require follow-up imaging, while uh, in 5 to 8% of patients, cross-sectional imaging, either CT or MRI, was used for initial diagnosis or response assessment. What was interesting was that we found was over the 10-year period, there was a twofold rise in the yearly CT and MR utilization for Crohn's disease. But the difference was the annual MR scan volume was showed a ninefold growth over the 10-year period, while the CT volume growth was stable. What that indicated was referring providers, radiologists alike are performing more MR enterography for evaluation of patients with Crohn's disease as compared to CT scans. It just shows evolution in the utilization of cross-sectional imaging in patients with a specific indication. What we also saw was the rising trends in utilization of cross-sectional imaging in this patient population also paralleled a 60% reduction in radiation dose over a 10-year period, indicating that the various radiation dose reduction strategies we have employed over the years was leading to reduction in the radiation dose. Now let's look at the second pillar of radiation dose reduction, that is optimization of CT protocols. That is, once it is decided that the CT is the most appropriate imaging techniques, it is now important to optimize the protocol. Now, when you think of optimizing CT protocol for any indication, the uh, cardinal principle is any CT imaging technique has to maximize diagnostic yield while minimizing the dose, so that it provides information regarding the not only the clinical question, pertinent clinical question, but also provides information about any incidental findings without providing high dose exposure to the patient. Now, if you think of a CT protocol, it's basically a set of parameters that specify a specific exam and provides details on the various components of a CT exam. If you look at an abdominal CT, there are multiple different parameters and components which contribute to a CT protocol in the abdomen, not only the use of intravenous contrast, but also use of oral contrast. Other indications need to be taken into consideration, such as patient's cardiac output, BMI, the clinical indication. The contrast media factors are also important from CT protocol perspective for timing of acquisition with regard to the clinical question, whether you want a multiphasic imaging versus a single phasic imaging. Additionally, with the introduction of dual energy CT, optimization of the dose for the single energy or dual energy CT protocol also becomes pertinent. So, in fact, if you look at it, CT protocol optimization is a complex matter, especially in the abdomen, with multiple different components involved. Now, if you look at our abdominal CT practice, we at MGH are fortunate to have a multi-vendor practice where we have nearly 23 CT scanners, and nearly more than half of those CT scanners are dual energy CT based. Now, we heard a terrific lecture by Aaron Sodikson on benefits of dual energy CT. We have also embraced dual energy CT as a technology which adds value in routine clinical practice. And if you look at the slide here, majority of our abdominal CT protocols for patients when they are scanned on a dual energy CT scanner are performed in the dual energy mode. So how do you optimize dose for the abdominal protocol? So now here, these are the four different indications I want to talk about. I want to mostly spend most of my time discussing what we have done to optimize dose for abdominal CT for stone protocol and CT urography, and then also spend time a little bit of detail on what we do for patients who present with abdominal pain and for patients with trauma. Starting with the urinary stone disease. Now, urolithiasis is a universal problem and affects patients both in the developed and the developing countries. Now, if you look at the US statistic itself, nearly 1.2 million Americans are affected annually by urolithiasis. And it is estimated that nearly 14% of men and 6% of women will develop stone disease during their lifetime. This disease also has a high relapse rate, with nearly 50% of patients having recurrent stone disease in the first 5 to 10 years after diagnosis, and 75% recurring within the 20 years. And if you look at the trends, some of the recent studies have shown that the prevalence of urinary stones has progressively increased in the past few decades, not only in the industrialized nations, but also in the third world countries. Imaging has a central role in the diagnosis of stone disease. Now, if you look at the different imaging modalities which are used in the management of stone disease, this include plain radiographs, ultrasound, and CT. Plain radiographs, or KUB, have a limited role as they are not sensitive because many urinary tract stones are not radio opaque, and many radio opaque stones get easily obscured by bowel content projecting over the urinary tract. However, radiographs are useful for treatment planning, particularly shockwave lithotripsy, and helpful in post-treatment evaluation of stent placement and estimating the residual stone burden. Ultrasound is now increasingly being performed for screening of patients with stones. Now, this modality is easily available, portable, and does not involve ionizing radiation. However, one of the main disadvantages of ultrasound is it is operator dependent and can be challenging in patients with large body habitus, particularly in the US. Anatomically, it's excellent for evaluation of stones in the kidneys and the urinary bladder, but is limited for evaluation of stones in the ureters. Stones appear echogenic on ultrasound, and you can see two examples here showing stones with the post-acoustic shadowing. While ultrasound has limited sensitivity for detection of stones within the kidneys, and when you compare to CT, it's highly sensitive for detection of urethral obstruction by demonstrating hydronephrosis in setting of acute flank pain. So ultrasound is not an unreasonable exam for surveillance of patients with known stone disease, particularly when it's combined with plain radiography. And it's often the test of choice for pediatric and pregnant patients, given the lack of ionizing radiation. Now, if you compare the sensitivity of CT and ultrasound for diagnosis of stone disease, this is a chart of multiple studies which demonstrates that CT continues to have a consistent high sensitivity compared to ultrasound. Now, I wanted to spend a little bit of time on speaking on role of ultrasound in uh, stone diseases, because of this seminal article which was published in New England Journal of Medicine, where Dr. Smith Bindman was the first author, which was a multi-center pragmatic comparative effectiveness trial in nearly 3,000 patients. What it did was it randomized patients into point-of-care ultrasound, radiology ultrasound, and CT for evaluation of nephrolithiasis. What they found was initial ultrasonography was associated with lower cumulative radiation exposure than initial CT, without significant difference in high risk diagnosis with complications, pain scores, serious adverse events, or return to emergency department visits. Now, they did notice that a significant number of subjects in the ultrasound groups, more so when the ultrasound was performed by the ER physicians than radiologists, required uh, additional imaging after initial ultrasound. And ultrasound was less sensitive than CT for diagnosis of stone disease, but it did not impact patient outcome. Now, in fact, following this study, there has been an increase in the utilization of ultrasound for evaluation of stone disease, especially in the ER at MGH. Now, it's relevant here because when we think of dose optimization, appropriate utilization with use of alternative imaging techniques is critical. Now, coming to CT. Now, CT has several advantages over other imaging techniques, including wide availability, accessibility. It can be performed rapidly, does not require the administration of contrast material. It's in fact, non-contrast CT is the initial investigation of choice in patients with suspected urolithiasis and has a very high sensitivity and specificity. Uh, it not only allows detection of calculi, but it also allows detection of other abnormalities like anatomic variants, infections, and neoplasms, which can have impact on patient management. It's been shown in studies that identification of urethral stones at imaging alters management in nearly 55 to 60% of patients who are suspected to have acute renal colic. Now, when we talk of a radiation dose with stone protocol CT, it is important to keep in mind that incidental CT findings not related to stone disease can sometimes have a higher impact on patient management. And that's something which we need to keep in mind when we are trying to optimize the protocol for dose reduction. That is, you do not want to reduce the radiation dose so low that incidental findings are missed. For example, in this case, was getting a stone protocol CT, the radiologist identified a mass in the tail of the pancreas, which turned out to be pancreatic ductal adenocarcinoma. Luckily, there was no distant metastasis, so this patient could still undergo distal pancreatectomy, but just highlights the importance of dose optimization and getting good quality images, not only for the clinical question that is for stone disease, but also for looking at other findings. Now, just quickly going over our MDCT technique, we perform all our stone protocol CT in the prone position, and that is because of specific requests from the urologists who want to differentiate stone stuck at the vesico-ureteric junction from bladder. We scan from the top of the kidneys to the bottom of the pubic symphysis to reduce the number of slices, thereby reduce radiation dose. Typically, we do not give intravenous contrast except in special circumstances. Now, when we talk of stone disease, because I'm a researcher who does research in stone disease, it's important to know that in this era of precision medicine, there's increasing expectations from urologists for information from CT scan, not only for detection of stone, but also information about fragility, composition, stone burden assessment, assessment of treatment response, and also use of CT as a biomarker for metabolic disease. So what do I mean by that? Now, there's increasing recognition that CT patients who have stone disease are also a part of a systemic disease where these patients not only have stones, but they also are likely to have coronary artery disease, atherosclerosis, metabolic syndrome, obesity, and diabetes. Now, why is this important? Because there's increasing interest in exploring the role of CT as an opportunistic screening method to identify patients who have these metrics which can be seen on CT, such as fatty liver, increased atherosclerotic plaque in the aorta, osteoporosis, which can have an impact on the long-term cardiovascular mortality of the patient. In addition, determination of stone composition also has an impact on patients' treatment decisions. For example, uric acid stones are managed medically, while patients who have calcium-based stones are usually managed by either shockwave lithotripsy or ureteroscopy. Why is this important? Because traditionally, determination of stone composition has been made on determination of stone attenuation, but there's increasing interest on using dual energy CT, as Aaron discussed in his lecture, for determining stone composition. Now, we routinely perform dual energy CT for all our patients who have a stone protocol CT on the dual energy CT scanner, because multiple studies have demonstrated that dual energy CT has very high accuracy for determining stone composition in stones which are over 3 millimeters. Just some example stone uh, uh, stone protocol CT, where how you can differentiate between uric acid and non-uric acid stone on patients scanned on dual source scanners and single source scanners. With that clinical perspective on looking at a stone protocol CT, not only from the perspective of detecting stones, but also characterizing stones, looking at the stone composition, but also looking for other incidental findings, or uh, uh, stone protocol CT as a opportunistic screening method, uh, that sort of opens up your perspective when you're optimizing the dose from a stone protocol CT. Now, as I discussed, stone protocol patients who have stone disease have a high relapse rate, with nearly 75% having recurrent stone disease in 20 years. So, a key concern when you do repeated CT examinations is high radiation exposure. Now, if you look at the effective radiation dose during unenhanced CT, it varies from 2 to 13 millisieverts, depending on the scan, 2 to 18 millisieverts when the scans are done between men or women. So when you look on optimization of CT protocols to reduce radiation dose, especially in patients who get multiple CT scans, there are several strategies you could utilize. Now, CT protocol optimization would involve making changes to several parameters to reduce radiation dose. Now, I'm going to discuss three important strategies we have employed in our practice in the past decade or so. One first step involves limiting the scan coverage area. So instead of scanning from the top of the diaphragm to the ischem, like an abdominal pelvic CT, we scan from top of the kidneys to the pubic symphysis for a stone protocol CT, thereby saving 10 to 15 slices, which can reduce the radiation dose by nearly 20%. In addition, performing targeted follow-up studies with scanning limited to the area of interest also minimizes radiation exposure. For example, scanning only the pelvis to confirm passage of a distal ureteral stone can limit radiation dose. The second strategy involves reducing tube current or MAS. Now, we use automated tube current modulation techniques for all of our CT scans for stone protocol. And there are certain operator defined parameters depending on the vendor, such as noise index or reference MA, which can help reduce the MA to accomplish dose reduction. Now, we employ different noise index or operator defined parameters based on the patient weight to make sure that we get good quality images, but also have reduction in the radiation dose. Previously, we used to incrementally increase noise index for follow-up stone protocol CT versus initial stone protocol CT, but in the past few years, we have gotten away with that approach, as it's often hard to identify those patients who have had prior scans. The other approach is low KVP exam. Now, stone protocol CT being a high contrast exam, reducing KVP not only reduces radiation dose, but also improves image contrast, which is particularly helpful for detection of calculi. Reducing KVP from 120 to 80 KVP can has dose benefits from 35 to 50%. Now, if you use a combination of these strategies, you can allow radiation dose reduction from anywhere from 40 to 70% from the standard dose. While these strategies can help reduce radiation dose, but they can increase image noise, therefore diminish image quality. Now, there are several different iterative reconstruction algorithms which have been introduced in the past decade, which help mitigate some of the image quality penalties. Now, these algorithms help diminish image noise, thereby improving image quality while reducing radiation dose. This is an example of a patient in whom dose reduction strategies and an iterative reconstruction algorithm was applied. And you can see on the follow-up scan in 2009 led to a radiation dose of nearly 2 millisieverts compared to 11 millisieverts on a prior scan. Now, despite the dose reduction, you can see that the image quality and the diagnostic performance are comparable. If you look at the literature and the timeline over the years, these dose reduction techniques have led to a significant reduction in dose associated with stone protocol CT. In fact, the time when an ultra low dose protocol CT, which has a radiation dose exposure lower than a 2 kV view KUB, might not be a distant dream. Also want to quickly touch upon the recent introduction of deep learning based image reconstruction algorithms, which allows even more significant dose reduction. One thing to note here is we spoke about radiographs. One method employed by our urologists here is in patients who require follow-up of stones. On a CT scan, if the stone has a density over 300 Hounsfield units and is seen on the scout radiograph, they get follow-up radiographs instead of a CT scan for follow-up of residual stone burden. And in those stones where the density is less than 200, a follow-up CT is obtained, something which helps in dose optimization. Now, in the next few minutes, let's go over some of the other indications where you can optimize dose. So I'm going to go over now CT urography. Now, CT urography is a technique which is used for evaluation of gross or microscopic hematuria. It is tailored for visualization of both the upper and lower urinary tracts. Multi-phase CT urography is the study of choice compared to MRI or IVU for evaluation of both the upper and lower urinary tract. If you look at the different phases from a CT urography, typically we have a non-contrast phase for detecting stones. You need a corticomedullary or a nephrographic phase for evaluation of renal masses, and a delayed phase for your evaluation of urothelial lesions. If you look at the data, CT urography has nearly 99% pool specificity for evaluation of urothelial lesions. Now, when you look at the different phases, the practice is all very variable looking at the different institutions or different papers. Now, the 4 phases which I described, non-contrast, corticomedullary, nephrographic, or delayed phase, can be used for evaluation of cause of hematuria. However, that leads to an increased radiation dose of nearly 25 to 35 millisieverts. So at MGH, we do what is called as a split bolus protocol, where after an initial non-contrast CT acquisition, the nephrographic and the delayed phase are combined. So what is done is initially we give a bolus of around 60 cc's of contrast, followed by a saline drip infusion. The patient waits for 10 to 12 minutes, and then a second bolus of contrast is given of 90 cc's, and a scan is performed at a delay of 100 seconds. So the second acquisition, which is performed after a non-contrast CT, now has 2 bolus of contrast in the kidneys as well as the collecting system, thereby allowing a combined nephrographic and delayed phase. Now, this allows a radiation dose reduction of nearly 25 to 30% compared to a triple phase CTU. Now, if you look at the literature, there is variability, but there's this paper from working group from European Society of European Radiology where they looked at CT urography based on indications, where they recommend a single phase combined nephrographic and excretory phase for patients with benign diseases, which could be the cause of hematuria. Two phase, where it's either extensive benign disease or low risk malignancy, or three phase for patients with the high risk hematuria or malignant hydronephrosis. Something more
Dr.
interesting.
Kambadakone,
Yeah.
I'm sorry. Quick time check. Uh, if you could wrap up in 5 minutes, we'll start the next talk, Dr. Rahani, at 11, please.
Okay. I should be done in 2 more minutes. Yeah.
Okay, thank you.
Perfect. Yeah. Thank you. So there's also recent interest in use of split bolus dual energy CT urography, where a single phase post contrast dual energy CT urography can replace a dual phase split bolus urography, where the virtual non-contrast images acquired from dual energy CT scan can be used as a surrogate for true non-contrast CT. In fact, several studies have shown that the virtual non-contrast CT has a similar pool sensitivity for detection of stones in split bolus protocols compared to true non-contrast CT scans. Okay, now going over two of the other indications. If you look at optimization of our pain protocol CT, we have a single phase portal venous phase CT for patients presenting with abdominal pain. A distinction here we do is we have two routine abdomen pelvis CTs, which is performed in the portal venous phase, a cancer follow-up CT of slightly higher dose, and a routine abdomen pelvis CT of lower dose for indications such as abdominal pain, hernia evaluation, uh, and routine indication. And the coverage for patients with abdominal pain is from the dome of the diaphragm to the pubic symphysis. Now, I'm not an ER radiologist, so I'm going to briefly go over how we optimize the dose for trauma protocol CT. Uh, the scan protocol depends on the type of trauma, whether it's blunt or penetrating. The default protocol is CT with or without contrast. It's a single phase scan. That is, if the patient cannot get contrast, if we do a non-contrast CT, otherwise all the patients get a single phase scan. The dose will depend whether the arms can be up or down, with the patients whose arms are up receiving lower dose. And there's also recent interest in use of single phase split bolus CT protocol, where both the arterial and portal venous phase can be combined. While it's important to lower radiation dose, it is important to know that low dose imaging should not be so low dose that you need to repeat the imaging because the images are not diagnostically acceptable. For example, these are the cases from our own institution where the low dose protocol it led to such a high image noise images that it was not diagnostically acceptable. So to summarize, dose optimization requires not only appropriate utilization, but also optimization of the CT protocol. CT protocol needs to be optimized to maximize diagnostic utility and minimize dose. There are numerous dose reduction strategies available for abdominal CT, and some of the newer CT reconstruction algorithms have enabled substantial radiation dose reduction. With that, I just want to recognize my team at MGH who are responsible for us to deliver a high quality imaging to our patients at optimized dose. Thank you for your kind attention. I know my time is up, but happy to